All right, so for this week on the lecture, we're going to be talking about joints. And when I say joints, I'm not referring to the ones that people might smoke. I'm thinking about these kind of joints here that I can pop. So this week, we're going to be talking about joints. So, all right, let's go ahead and get started. So, a joint is an articulation, which we've talked about articulations before. So, articulations are places where bones are going to contact or meet. So that is referred to as a joint. So a joint can be between bone and cartilage or between bones and teeth. There are different types of joints. So we always think about joints like our fingers that we crack or our knuckles, but any place where a bone articulates, that is a joint or where they contact each other. So there's three different types of joints. So we have fibrous, cartilaginous, and synovial. So fibrous it got kind of sounds like what it is. It's a dense, regular connective tissue that holds together ends of bones and bone parts. So there is no cavity, but it's fibrous, means that there are fibers or collagen fibers, which we know that that's going to be in dense, regular connective tissue and dense irregular. But remember, dense irregular looked like lasagna noodles. It had all those dense collagen fibers that were embedded in it. Cartilaginous there's going to be cartilage. So there's a pad of cartilage, just like in our vertebrae, those little cartilages in between our vertebrae, the fibrocartilages, that's going to be wedged in between bones. And then you have synovial, which is going to be a capsule. And when I say capsule, kind of think about like a pill when there's a capsule, which means there's something inside that pill. Synovial is going to be a cavity that's going to have fluid. And that fluid is going to be referred to as synovial fluid. So this is going to separate the articulating bones. It's also going to be lined by a synovial membrane, which is going to produce the fluid. And so this just also helps reduce friction. The reason why there's fluid is just to reduce friction and also to be as a shock absorber, excuse me. So with all those joints, the movements can be functionally categorized. So you have synarthrosis, which means that joint is immobile or is unable to move. You have ampiarthrosis, which means it's slightly able to move. And then you have diarthrosis, which means that joint can move freely, kind of like our fingers. They can move freely. So here it gives you some examples here. So like an immobile one would be like a suture, just like in our skull. Slightly mobile would be like in our back. Our back, our vertebrae in our back can move, not too drastically, of course, because remember we have a spinal cord running down the middle, but they can shift a little bit. Even when you walk or sit down for long periods of time, those cartilages can compress, they can kind of move a little bit. Sometimes that's why you have to go to a chiropractor to get readjusted. And then you have mobile or free or very mobile, which be like your knee joints, because we know that we can flex them and extend, just like our arms. We can move those around. Sutures are going to be you can't move them. The vertebrae, you can move a little bit, but then you can get to joints that are like our arms and our legs that are constantly always moving. So those would be the three functional groups. So if we dive a little bit deeper into it, have with the fibrous joints, we can have some different type of fibrous joints. Remember, fibrous joints are bound by a fiber, or they have dense, regular connective tissue that holds the bones together. So in this case, we have what's called a gomphosis, which when I think of gomphosis, I think of gums like in your teeth. Um, all these little ligaments around the teeth are called periodontal ligaments. So anytime like you get, if of you have had braces in the past or use Invisalign, the the braces or Invisalign are actually targeting those periodontal ligaments. That's what's actually causing your teeth to shift and change the formation. So anytime braces have been used after so long, you have to get them retightened so that it can start pulling on those ligaments to help start straightening your teeth. So that's the purpose. So that's the purpose of those periodontal ligaments, and it's also to anchor the tooth to the mandible or the maxilla in the alveoli processes. Now, also with that being said, teeth are not bone. However, you have to be able to anchor your teeth to the actual bone, which is going to be maxilla or the mandible, so that they stay in place. I mean, how interesting would it be if you were eating and then your teeth would just slide out of socket? You wouldn't be able to eat very much because you'd have an issue with keeping your teeth in your mouth. So we have periodontal ligaments that are going to keep the teeth anchored and attached, as well as keep them in their sockets so that they don't move. Now, interesting enough, our teeth over time do move. That's one reason why our teeth can be straight when we're younger, and then as we get older, they can shift. I mean, think about you eating, crunching chips. Ligaments are pretty strong, but they can essentially become a little bit flexible and shift. If you grind your teeth at night, if you chew too hard, I mean, it can cause those ligaments to move a little bit. And over time, it can cause them to shift. I mean, our mouths kind of shift as well as we get older. And so there's a lot of different things that can cause your teeth to shift. So may not drastically to where you need braces, but over time they can shift. Then you can have a suture, which we see sutures typically in our skull, because remember, we have to give that room to expand until we're done developing. And a suture actually kind of looks like if you ever sewn something with a needle and thread, it actually does kind of look like a suture. Or if you look on your clothes, you see that there's stitches. That's kind of what that suture looks like. Those do not move at all. So those are referred to as synarthrosis. And then you have a syndesmosis, which is going to essentially be a membrane between two bones. And here you can actually see in between the radius and the ulna, to keep those two together or for stability, it is going to have a membrane between those two bones. So even when you rotate them so that they don't kind of spread apart too far from each other, it keeps them there. It keeps them in precise formation. In cartilaginous joints, which means that they have cartilage at the ends of the bones, so you can find those in synchondrosis, which is going to be essentially hyaline cartilage. Those you can find especially in our long bones and then in around the ribs. So if you've ever had to give CPR, been CPR certified, one way that you can always know that you're doing CPR correctly is if you can hear those ribs crack or break. And typically, with the heart being right here in this area right here, you're going to essentially break through this cartilage and potentially some bones or some ribs in this case. Um, Also, these cartilages, even though they're supposed to be pretty immobile, ribs 2 through 7 tend to be a little bit more mobile. So you have to think about it when we are taking a deep breath, that rib cage is moving. We have our internal, external intercostals moving that rib cage to expand it so that your lungs can fully essentially inflate and deflate. So there is just a tad bit of movement that's going to happen with the ribs. However, they can't move as freely as our arms can. But there is some movement there, and that's one reason why we have cartilage. If they were completely just bone attached to the sternum or ribs attached to the sternum with no cartilage, it'd make it very difficult to breathe, and it would kind of essentially could potentially damage our heart, or it would make it very difficult for the lungs to expand. So that's one reason why we have cartilage at the ends of those ribs, is just so for just a tad bit of expansion, just enough so that it keeps everything intact and protected, but also allows for room for things to expand. And B, we have symphysis, which is going to be in between, or it's going to contain fibrocartilage. Remember, fibrocartilage is only really found in our pubic symphysis and in our or in between our intervertebral disc or vertebrae, essentially. So fiber cartilage essentially is going to deal with compression. And if you think about it, our back takes a lot of compression. Even with us standing or sitting, our back is constantly being compressed. It's holding up all of our body weight. And it has the help of muscles as well. But also our sacrum is taking a lot of our weight and it's being spread to our coxal bones or the pelvis itself. So that pubic symphysis is the little bit of cartilage that's going to be in between those two coxal bones, which or actually more specifically in between the pubis bones or the pubic bones. Sometimes during birth, that it tends to end up having to be broken or may come apart. Sometimes it has even had to be cut through for childbirth. But moreover, it's usually just for the connection of those two bones between the two coxal bones, and for compression and for shock absorbing of the vertebrae. So not a disorder, but a condition that can happen is called costochondritis. So costochondritis, if you break that word apart, costo means rib, chondro means cartilage, itis means inflammation. So if you put that together, we have inflammation of the ribs and the cartilage, or the cartilage of the ribs. So if you remember looking back at this picture up here, the cartilage can essentially have inflammation, which means there's pain, swelling, tenderness, heat, potentially redness there. So if these cartilages gets inflamed and you start feeling pain there, to imagine how this would actually feel would be if every time you took a deep breath or took a breath, it would hurt. And every time you breathe out, it would hurt. Some people tend to think the symptoms can be so bad that some people can mistaking it for a heart attack because it's so painful. It's usually right there in your ribs. It's right there at your sternum and kind of more towards the lateral portions of your sternum. So every time you take a deep breath or take a breath, it would essentially be a lot of pain. So the only way we can actually treat that is predominantly with NSAIDs like ibuprofen, which stands for non-steroidal anti-inflammatory drug, or aspirin. And so usually we have to give you a lot of rest, and hopefully that the symptoms might disappear in a few weeks. It's very difficult for this condition to essentially heal just because you have inflammation of those cartilages. However, you have to breathe. You're breathing constantly. So it's kind of hard for it to heal and you're steady expanding those cartilages every time you breathe. It's kind of hard for it to heal because you're constantly using it. So that's one reason it takes a long period of time for that to heal. There has been conditions or times where people have had this condition and it's taken a long period of time to heal, and sometimes shorter. But usually it's going to be a very painful type of thing. And sometimes it has referred pain to where it's on your side, but usually it's going to be kind of right here around your sternum, which is one reason why some people can think that's a heart attack. So with synovial joints, remember synovial joints have fluid. So if we take a look at this picture here, we can see our bone, and we can see our yellow bone marrow and our spongy bone, and then the epiphyseal plate. So we know that this is an adult. But around these bones, we're going to have an articular capsule. So remember, our capsule is going to contain something. In this case here, which in the green, within the purple here, excuse me, we have the synovial membrane, which is going to essentially trap all the synovial fluid and help conduct the fluid in and out of the capsule. So the reason why we have fluid in between joints is for compression and also for the reducing of friction. The synovial fluid actually is kind of a greasy type of fluid. It's not like water, but it's kind of more of like a oil based, but predominantly is made up of water components. But it's going to help the articular cartilages, which you should remember from the bone chapter, that each long bone that articulates with another bone is going to have hyaline cartilage, which is nice and glassy. That's going to make it nice and smooth. The synovial fluid is going to nourish this cartilage here. And by nourish, just like we have to nourish our bodies, we have to give it food for it to heal, for it to operate properly. The chondrocytes, which are the cartilage cells, have to be nourished. They have to be given their ions, their cells. They have to have ions, glucose. They make waste. They have to get rid of that waste. They're just like the regular cells of our body. So they have to be nourished. So the fluid is what's going to provide the nourishment. It gets its nourishment from essentially blood vessels that's going to carry glucose, your ions, your salts, um, your oxygen. It has to get that from the fluid. They don't have a direct blood supply to the cartilages, but the synovial membrane does. So the membrane here has blood supply, which is how it gets its nutrients, but the cartilage itself does not have a blood supply. So in your hand, or actually just around places where there are tendons and bones, or tendons and ligaments, remember tendons are going to allow muscle to attach to bone, and ligaments allow bone to attach to another bone. Sometimes, remember, we have articulating cartilage to reduce the friction between two bones. However, there's more things that are moving. We have tendons and muscles moving, as well as ligaments sometimes can move or provide stability. So we have to be able to reduce the friction of our muscles that are gliding across different ligaments and tendons. So we have what's called a bursa, but you can see that we have these right here. So here's a bursa. So these are fluid filled, I call them fluid filled balloons. That's going to help reduce friction, or kind to reduce friction between muscles and tendons and ligaments. We also have what's called a tendon sheath, which is going to essentially wrap around a tendon where there might be excessive friction. They're going to be really common in our wrist and our ankle. So things, because we're always doing this, so there's a lot of movement that's happening here. So we're going to have tendon sheaths. Now, if you've ever heard of something called carpal tunnel, if you look here, we have this sheath here that's going to wrap around, as well as this one. Sometimes there's a nerve that runs in between there. Sometimes that sheath can kind of compress it, and it's going to cause a tingling sensation to happen within our hands. So that's how we call it carpal tunnel. Remember, the carpals are the wrist. And so it's a tunnel that the nerve goes through a sheath, which makes a tunnel, goes around it, and it actually compresses it. Just like you would see here, it goes underneath here, and sometimes it can compress, and it essentially pinches it, and then it makes it kind of feel like a shocking pain or numbing pain. You can also have what's called a fat pad, which are essentially what you see right here. These are going to be essentially adipose tissue or fat tissue. That's going to act as packing material, which is kind of helps protect the joint. Cracking knuckles. So that's something I like to do, and I can kind of do all day long. Um, However, it is a myth, and I am glad to debunk it for you that cracking your knuckles does not lead to arthritis. And it's even in this book in the last sentence. I'll make sure to highlight it for you. There was a doctor who cracked his knuckles for 60 years straight and won a Nobel Peace Prize. And he actually demonstrated that you can crack your knuckles for 60 years straight and you won't get arthritis, or at least he didn't. So that myth has been debunked. However, cracking your knuckles, what actually is happening is that you have gases that are in that synovial fluid, just like we talked about up here. So in this membrane, we can have gases, because remember, we have gases in our blood. We have oxygen, we have nitrogen, things that we breathe in from the air, and those get trapped in this fluid. Well, when you crack your knuckles, you're pushing on that membrane and you're causing a pressure difference, which is going to press those air bubbles out of the membrane, and that's what you hear crack. Now, if you notice, if you ever cracked a knuckle or cracked um, your neck, you can't do it right after you did it. It takes a few minutes. It actually takes, on average, about 20 to 30 minutes for those air bubbles to dissolve back into the synovial fluid so you can crack it again. So crack your knuckles is literally just, you're just hearing gas leave your synovial fluid or your joints. That is what cracking your knuckles is, which for years they didn't know what was actually happening. And that's why they had so many different things that they were saying that could potentially happen, but that's not true. So cracking your knuckles is just, you're just changing the pressure difference, which is just pushing air out your knuckles or out of your joints. So we have different types of joint movements or different classifications of joints. So we have like a hinge joint, which would be an example would be your elbow. So I can take my elbow and extend it just like a door hinge. You know, you can close a door, you can open a door. The same way a door hinge works, our elbow works that exact same way. We have a plane joint, which it's uniaxial, so it does not really move. So like our wrist bones, they don't move. They're pretty much in place. They don't really have much movement unless you sprain them or you fracture them. They really don't typically move. You can have what's called a saddle joint or a biaxial, which means there is some movement. So think about like if you're in a horse's saddle, you can move left to right in that saddle, and you can also move front and back in that saddle. So a good way to think about this, and it gives you an example. So if we look at our thumb, if we take our metacarpal, that can move frontward, backward, and side to side. That would be a saddle joint. Because just like you're in a horse's saddle, you can move side to side and front and back. You have condylar joint, which that would be essentially I can move it up and back down. And I can kind of move it side to side, but actually I can only move it up and down. So if I took my index finger, I can only do it like this. Now I can move it side to side down here, but not in this actual phalange. So in my proximal, middle, and distal phalanges, I can only move it up and down. And I can kind of move it. I can wag my finger, but that's the only motions I can make. I can't do too much with it. I can only go in certain directions. So that would be condylar. And then you have ball and socket, which the only ones we really have that's ball and socket is going to be our humerus, which the humerus head goes into the scapula and the acromion and the coracoid process and the glenoid cavity. And it's allowing us to have rotation like this. Same thing with our leg. You can move your leg in a circle up and down, side to side is a ball and joint type of joint. And then at the bottom here, we have a pivot joint. So remember, like in your head, that C1 and C2, C1 being the atlas, C2 being the axis, you can move your head left to right, up and down. It swivels kind of thing. It pivots. It goes back and forth. So these are different classifications of movements that our joints can actually do. So we have some different angular motions. So we've heard of flexing. So if I say flex your muscles, we always do this. We've always seen on movies or TV shows where they flex their muscles and do this and this. But what is actually flexing? So flexing is decreasing that angle. So we look at here, if you took this angle here, this is 180 degrees. If I decrease that angle, this is 90, this is 45. This is flexing. I'm decreasing the angle. That angle went from 180 to 90 and then to 45 and 30. That is decreasing the angle. That is flexion. If I do the opposite, which is increasing this angle, which I'm going from 30 to 45 to 90 to 180, that is extension, like I'm extending my arm out. It's extension. Now, with lateral and medial, we know that lateral means you're going away from the midline, and then medial is coming towards the midline. So even though this is flexion, I can do this with my hand. So this is flexion because I'm decreasing the angle. This is extension. So this is 180 right here, decreasing my angle, that is flexing. If I increase the angle, and this is the angle I'm referring to, this is 180. Now I'm at essentially 270 or 175. I am increasing that angle. So this is the angle I'm referring to here. So decreasing, increasing. Flexion and extension. We can have what's called abduction and adduction. So abduction, like your abs, abduction, which I hate to think about like this, but it's one way I remembered it when I was in college. If a child is being abducted, it has been taken away. So abduction is being taken away from the midline. Adduction, like adding or subtracting, adduction is getting closer to the midline. You're adding to get closer to the midline. So abduction with an B, abduction is taking away, like being abducted. You're being taken away. And adduction is bringing it closer to. So you can do that with your hand, which I can never do the Star Trek sign. But if you do your fingers like this, you go like this, is being it's abduction. We bring it back to is adduction. So abduction, adduction. And then circumduction, which means that one of the proximal end of the appendage, which would be like, let's say my shoulder, of course, would be proximal, is closer to my trunk. This proximal end stays in place while the distal end is what's going to turn. So it's making like a circumference of a circle. I'm making a circle, essentially I'm circumducting, or circumduction is the movement that I'm doing. So one end stays in place, the other end is making a circular angle or movement. Rotation. So rotation means that the bone makes a pivoting turn, or just rotation means to turn. So we can have lateral rotation, which lateral rotation means that I'm turning to the lateral portion, which is going to be turning to the outside. Medial rotation means I'm going towards the inside. So, or towards the midline. So this would be medial rotation. Now I'm turning towards the lateral, which is going away from the midline. Pronation and supination. And how I always have to remember this is if I'm laying face flat, I am prone to getting walked on top of. If I'm laying flat on my face on the floor, like laying face flat on the floor, I'm prone for someone to walk on top of me. So prone is face down. Supination is laying face up. And I always think of, I used to play peekaboo with my niece. And so I would essentially, every time I was on my back, I'd be laying face up and would say, surprise. I know it's a crazy way to remember it, but supination is laying face up. So pronation is face down, supination is face up. So when we're in anatomical position, remember your hands are out to your sides, your palms are facing out, or your palms are in supination or supine. So face up, face down. So if you looked at it like this, right now the palm of my hand is face down. So this would be my face. So let's say I drew a face on my hand. Face up is supination. Face down is pronation. Same difference if I turn like this. This is pronation, supination. You can see my face. You can see the face on my hand now. So pronation, supination. Face down, face up. And then rotation, of course, rotation is just turning. So you can rotate your head. Rotation just means turning. You can have elevation and depression. So when I think about elevation, I think about going up or like an elevator, right? So let's say I put my shoulders up and now let my head go up. That is elevation. If I make my head go down, that is depression. Dorsiflexion and then plantar flexion. So we remember from regions, this is the dorsum of the hand, right? So dorsum would be the back of your hand. So dorsal flexion, so if I redo this angle again, this angle is 180. If I flex, it means I'm going to decrease that angle. So that means this would be flexing. I went from 180 to 90. That is dorsiflexion because this dorsum in my hand is flexing. On the bottom is the plantar. So if I'm going to flex the plantar or the plantar region, we're going to be looking at this angle. So right now this is at 180. I'm decreasing that angle to 90. This is plantar flexion. If I want to do dorsiflexion, it's the back of the hand, I'm going to do this. If it's plantar flexion, I'm going to plant my foot or plant it downward or plantar flexion. Protraction and retraction. If I protract something, I'm pushing it outward. If I retract something, I'm pulling it back inward. I'm retracting it. I'm pulling it back. Just like if someone retracted a journal post, you're taking it back. So retraction is taking it back. Protraction is pushing it out. So there's a type of disorder with a joint called TMJ. So TMJ stands for temporomandibular joint. If you don't know what that is, break the word apart. So temporal would mean your temporal region. Mandibular would be your mandible. And there's a joint. So this is where a joint is where two bones meet. So the place where your mandible and your temporal bone is going to meet is going right here in front of your ear. And if you kind of chew, you can actually feel it moving. You can feel this part move, kind of bulge in front of your ear. That is your TMJ, or temporomandibular joint. Sometimes it can essentially the articular disc in that joint can pop out or cause a clicking or popping noise. So essentially, every time you would open your mouth, it would kind of like pop out of place, and then it would pop back in when you moved your mandible. You can typically feel this pain um, within your nasal sinuses, your eardrum, sometimes in your oral cavity or in your eyes and your teeth. Remember, there's a nerve that runs in your face that runs down the side of your face. So it sometimes can innervate that and kind of aggravate that nerve and cause nerves all in your face to essentially feel that pain of that joint. So essentially, um, you can also feel it in your chewing muscles, which like your masseter, your buccinator, um, your zygomatic. So all these bones all these muscles in your face that you use for chewing, that surrounds your mandible, which is your jawbone, that can essentially be affected or can essentially feel that pain from that joint. And so sometimes there's quite a few people that actually kind of suffer from this. So here you can actually see where this is actually going to be on the skull. So you can see, remember, there's two bones being connected together. So there's two bones connected together. It's going to be a ligament. So ligaments connect bone to bone. Tendons connect muscle to bone. So here you can actually see the ligaments, the temporomandibular ligament that's going to hold that together. If it becomes too loose, your jaw can essentially pop out of the joint and cause issues. Here we can see with the clavicle end or the sternal end of the clavicle, how it actually articulates with the manubrium of the sternum. You can see that we have ligaments here. So the sternoclavicular ligament. So the ligaments kind of tell you where they are attaching to, what they're attaching. So sterno would be the sternum, clavicular would be the clavicle. This is where they would actually articulate. So even though in bones we show how which bones touch each other, they're held together by ligaments. So here we can see with the clavicle and the humerus how we all have all these ligaments. So we have the coracovicular ligament, which is going to be attaching the coracoid to the clavicle. We also have the acromial clavicular ligament, which is going to attach the acromion process of the scapula um, to the coracoid or to the humerus. And then we have the glenohumeral ligaments, which are going to essentially encapsulate the humerus head of the humerus to that glenoid cavity, which is going to be inside the scapula. Here we have a subdeltoid bursa. So sub means below. Deltoid is the region and the muscle that is actually right here. That's our shoulder muscle, our deltoid. So remember, a bursa is going to essentially help cushion and help glide muscles when they are moving. So think about like our arms, we have bursa. If those bursa get infected, which would be referred to as bursitis, bursitis essentially is going to be inflammation of the bursa, and that's going to cause it to swell, and that can potentially cause pain. So some people think that they're having a torn muscle, when in actuality, it's actually a bursa that has been slightly inflamed or sometimes a little more severely. And essentially, it causes a lot of friction and issues between the bones, and it pushes on nerves. And so usually there's a lot of discomfort in once you get bursitis. Remember, bursitis is going to be really in your arms, your knees, where there's going to be a lot of muscle movement around tendons and ligaments. And so here you can actually see what it would actually look like. So you can see the humerus head, you can see where the tendons are going to connect, where the ligaments are actually connecting. So this is what we actually look like in us. And then so here, it gives you a better representation of how the glenoid humeral ligaments are going to look like. We have some muscles. We can see how some ligaments, the infraspinatus tendon. We can see how all these are coming into play and making up that joint. So that the joint is not just where the bone meets, but it's also everything that's helping keep that joint in place. Think about it, we do all this movement, we have to be able to keep those bones intact. If not, we run into something called dislocation. So if those ligaments become too loose or some type of trauma happens, it can cause your shoulder to essentially dislocate or um, a joint to dislocate. So you got to be careful with that. And usually we tend to see them when I was an athletic trainer. We saw this kind of happen a little frequently. Um, but here's the thing with dislocating joints. It's okay to dislocate a joint one time as long as it's put back properly, and that it can go back in properly. However, typically after it has been dislocated, it makes it very difficult, or it's actually very easy for you to have another dislocation in the future. And as you have more dislocation, it becomes a little bit more prone. You can become more prone to having dislocations. The only way to really kind of stop that if you start having them frequently is essentially to have a type of surgery. And essentially, they have to either take another ligament out of you and replace it with the ligament in your shoulder or wherever you're having issues, or sometimes they can put an artificial um, ligament into you. So it just kind of depends. But typically, the more you have dislocations, the more dislocations you end up having. You'll be more prone to it. So here we can actually see what a normal shoulder joint or glenohumeral joint would look like. And here at the bottom, we can actually see what it looks like dislocated. So here we can see the clavicle and the acromion, and here's the head of the humerus. It's kind of like it has just dropped out of socket. And here we can actually see what it looks like on a person. We can see that the shoulder is kind of really square because now we're seeing the acromion and the coracoid process. So it's very, very squared off. And then here we can see the head of the humerus is kind of just hanging or kind of really just sagging in the arm, really. So here we can see that it's become dislocated. It almost looks like a normal shoulder, but this is way too square for our shoulder. Our shoulder is kind of curved. Even looking at mine, there is a certain curvature. This one I can actually get an angle. This looks like a 120-degree angle. And so here, if you remember studying those landmarks, those bones and landmarks, we had the epicondyles, we had styloid processes, tubercles. Remember, those were places where we're going to have ligament and tendon attachment. So here we can actually see how these are going to attach to the epicondyles in the humerus. It's going to wrap around the radius head and the ulna head. Remember, ligaments attach bone to bone, and it also keeps them together. We want our bones to stay together. We don't want them just be floating in our arms or in our legs or inside of our skin. We want them to keep them together. Structure determines function. So if the structure becomes compromised, it doesn't function the way it is. If the ulna was to become dislocated, it wouldn't be able to function properly. It would be kind of just getting hung um, within the skin and the ligaments. So here we can see how we have an angular ligament, which is going to essentially, it's going to fold over the head or the neck of the radius, which allows the radius to actually turn. So it actually essentially is like a seat buckle or a belt or seat belt buckle for the radius or the neck of the radius. We can also see here on the coronoid process as well as the olecranon process of the ulna, we have attachment that's going to help keep um, the ulna around the trochlea of the humerus. Subluxation is essentially, or subluxation of the head of the radius. So if you are essentially swinging a child like this, it can actually pull the angular ligament. So this ligament right here, the ligament that's the seat belt for the radius, remember the radius had like a knob-shaped head. If you are pulling on a child, it can cause that essentially that radius to pop out of that seat belt essentially, or that annular ligament, and essentially dislocate that whole joint. So that's one reason why you should not pull on a child this way, because if you look here, it's putting a lot of tension. So all their body weight is essentially fighting against that joint. And so you can do a lot of damage by separating them. So typically, this injury usually commonly occurs in children, um, usually younger than 5 years of age. Remember, during that time, our bones aren't completely calcified; they are or ossified. They're cartilaginous, so they're very flexible, just so that they can grow more. But at the same time, they're flexible, and so if you do too much exertion on them, it could cause them to pop out of place or cause damage. So here we can actually see with the trochanters, remember the trochanters were found on the femur. They're only found on the femur, but those trochanters were sites of attachment for ligaments. And so here we can see that we have an iliofemoral ligament. We can see we have the pubrofemoral ligament. So ilio, remember it would be the iliac bone, so it's iliac to femur, and then the pubofemoral ligament is going to be from the pubis to the femur. Those ligaments are going to help attach and keep the femur attached to the pubis or to the coxal or the pelvis bone. We want those to remain connected. You don't want to be walking down the sidewalk and then your leg pops out. Then you will be on that commercial like I've fallen and I can't get up. So we have to those ligaments have a very important job of keeping the humerus or the femur and the pelvic and the coxal bones together. Now, on the inside of the acetabulum or the acetabulum, as I like to pronounce it as, we see that if you remember on the femur, it had like a little bitty pit in the head. That pit is called the fovea or fovea capitis. That fovea is going to be the site of attachment for the ligament. So the ligament of the head of the femur. Now, that ligament is not necessarily for stability. There is a blood vessel that runs through here. That blood vessel is going to essentially allow for nutrients to come into the cell or come into the bone and leave the bone, as well for transfer fluid into the synovial fluid. Also, remember, here we can kind of see that we have red bone marrow. Remember, our red bone marrow produces 300 million red blood cells per second. It has a really big job of producing your blood. So it has to have some way for it to travel. There are also blood vessels in the medullary cavity, but also it can also be supplied. It can also have like a pipeline of getting blood out of this as well. But morally, it's usually morally for putting blood into the bone and shipping it out. So we can have fractures. So typically, a common fracture in the femur is going to be in the neck. Now, the femur is the strongest bone in your body. The femur can actually hold up an elephant, about proportionate to your body. It's your strongest bone of your body. However, if you get a crack or a fracture within the neck of the femur, which is right underneath the anatomical head, not the surgical neck, but the anatomical neck, we refer to that as a fractured hip. To fix that fractured hip, which typically happens in elderly people due to osteoporosis or osteomalacia, we can see here in this x-ray that the neck of the femur has been cracked or broken. So to fix that, you can see here they've put in screws. And those screws will stay with you for the rest of your life and even after your life. Sometimes, as a result, the head of the neck of the femur may lose blood supply and develop a vascular necrosis. Avascular means there's no blood vessels. Necrosis means that you're having cell death that's not programmed. You're having random cell death. That's not something you really want in your legs. So when you're walking and you're having that, I mean, you can essentially crack your bone, then your bone can start deteriorating and essentially breaking itself down. And then eventually they have to essentially amputate, which means to cut off your leg. Um, Same thing with people who have diabetes. That's why they have to get toes amputated, is because essentially that tissue starts to die and they're trying to preserve it from essentially spreading to other places. So they'll chop off a toe or your foot to keep that disease from spreading up the bone. Because once you get into your bone, remember your bones make your bloodstream or your blood supply. And once you get into your blood supply, it goes everywhere. So that's one reason why they are, especially with people who are having those type of diseases, they tend to cut off limbs to prevent disease from spreading further. So here, we can actually see the knee joint. So our knee is comprised of our femur and our tibia and our patella, and also a little bit of the fibula. So here we have our condyles, which we learned in bone markings, which are large oval-shaped surfaces. This is going to be hyaline cartilage. The medial condyle, which just means that this is the midline of us, and then the lateral is going to be on the outside of us. The fibular collateral ligament, so fibular is going to tell you that it is connecting to the fibula. So it's collateral, which means that there's two. You have the anterior cruciate ligament and then the posterior cruciate ligament. You usually hear this referred to as the ACL and PCL. You typically hear this one more commonly just because ACL tears are pretty common. So when I was an athletic trainer, we saw a lot of athletes that would have this type of tearing in this ligament here. So ACL stands for anterior cruciate ligament. So this ligament here has a responsibility for not allowing your leg to flex too much. So if your leg was flexing at the knee, so if your knee standing like this, it stops it from over flexing. And then your posterior cruciate ligament prevents you from overextending. Now, sometimes when you're running, especially like with athletes, if they're running a long portion of time or doing too much on their legs or their knees, it can cause this one to rip. Or if they fall or they trip or they fall on it wrong, it can put a lot of stress on this. So if we take a look at this one here, when you bend the knee, you're putting a ton of stress on this portion here. Bending it just it stretches the anterior cruciate ligament. So think about when you're running, you're causing a lot of stress to happen right here on this ligament here because it's constantly stretching. The back one doesn't really stretch very much. The posterior one doesn't really stretch, but that anterior one is constantly stretching. And ligaments can stretch, but you can also stretch it beyond the point that it's supposed to be stretched. So that's one reason why anterior is usually the one that's usually going to be the culprit. It's usually the one that's going to be torn. Sometimes we can go in there and stitch it and it'll heal within a few weeks or months. Or sometimes we have to go in there and replace it with a piece of a ligament from somewhere else. Or sometimes, in some cases, if it's severe enough, we'll replace it with an artificial one. Now, whether they recover very well or very often, probably it depends. It depends on physical therapy. It just depends. We have what's called a meniscus. So the meniscus are going to be pads or cartilage pads that sit between the femur and the tibia. So I actually, when I was 15, I was in a school bus wreck. And so I tore this from the impact of the bus hitting the 18-wheeler. It caused my knee to essentially jam into the back of the seat, and it should have torn my ACL, but it did more damage to my meniscus. The meniscus is the cushion between your femur and your tibia. So if you can imagine, if every time I was walking down the stairs in my high school, I could not move. It was very difficult to walk downstairs. I would almost start crying from how much pain I was in. Essentially, my meniscus was kind of really gone, and so my um, femur and my tibia was making contact. So that was very rough on my legs, and it would hurt. The meniscus is for protection, and so they went in and they trimmed it and then sutured it, and it took probably about a few months to really heal. I was unable to walk for a few days. Even though I was a little stubborn, I still tried anyhow. But there's a lot of muscle tissue you have to cut through. So if you look here, you have to cut through all this muscle tissue to get to the meniscus. So when you cut through muscle tissue, there's a lot of inflammation, there's going to be a lot of swelling, a lot of pain. But I'll never forget the meniscus because that's what's keeping the cushion between your femur and your tibia. Here we can see all those tarsal bones and metatarsals. We can see all your ankle bones, all those bones that make up our ankle are connected or they articulate with other bones. So that is going to have to, all those we're going to have ligaments. Ligaments are attaching bone to bone. So all these are ligaments that you're seeing here. Now, sometimes these ligaments can stretch, and that's going to cause what we call a sprain, like a sprained ankle. A sprained ankle is where these ligaments essentially become loose, or you've done something, you've stepped wrong, and you have overstretched these ligaments. That is what a sprain is. And we know that a sprain can essentially be fixed within a few weeks, within a week or two, depends on the severity, but typically it can be fixed regularly. And so we can see here we have a ligament that runs on the bottom of our foot. And then if you've ever had if you've ever had your foot arch fall, it can be very painful. Also, this plantar fascia, which is what this ligament is referred to as, it can become inflamed. And I've had that happen. If this becomes inflamed, remember your feet carries all of your weight. And if this becomes inflamed, it hurts. And so if you just stand on it, it hurts. And if you try to walk on it, it hurts and also makes it worse because you're stretching it and it's trying to heal. It's almost like costochondritis. It's not going to heal very well. And so it takes a while to heal. And the only thing I could take for it was a ibuprofen. It worked pretty well. And it got better within a week. But this ligament here, all these ligaments have a very important role. And if they are stretched beyond their means, it can cause a lot of issues and pain. So here we can see what the meniscus looks like. But this is what mine looked like when they went and cleaned mine. So you can see here, if someone got kicked in the knee or got a blow to the knee, you can see those collateral ligaments. This one, it's sprained, it's definitely weakened, but it's still intact. But if we look closely, we can see how the anterior cruciate ligament is torn, but the PCL isn't. We can see the meniscus is torn, and we can also see how this collateral ligament is torn. So typically, the PCL does not get torn. It's rare occasions it does, don't get me wrong, but typically the ACL takes the biggest hit, and that's usually the one that's going to be the most commonly torn. So there's different ways you can test this. It's called the drawer test. So if you have too much forward movement, so let's say if you were sitting on a table and your legs were dangling, they essentially pull on your knee. If it pulled forward like a drawer, that essentially would mean that you had an ACL tear. And if your leg went too far, if they pushed it back and your leg would go in like a dresser drawer, that would essentially refer to as the posterior drawer test, which would essentially say that your PCL was torn. So there's a few ways we can do simple tests to figure out which ligament is damaged without having to essentially do an X-ray or a CT. Um, but either way, they hurt regardless because there's a lot of compression, a lot of movement. You got bursa there, you got a lot of muscle there, so there's gonna be a lot of inflammation. And remember, your knees are what's responsible for allowing you to stand straight up. Your knees lock once you're standing. That's what allows you to essentially stand properly. If you don't lock your knees, you'll essentially kind of fall. There's really dependent on your muscles to kind of keep you standing. However, you can also lock your knees for too long and essentially pass out. So there's always a balance, but typically that's one reason why we're able to stand straight up is because we can lock our knees into place using our meniscus, essentially. So aging of joint. So aging of a joint is also referred to as osteoarthritis. It also can be degenerative, which means essentially it can essentially start breaking down. Um, with joints, it's actually imperative that we essentially exercise. By us exercising, it's allowing for new fluid to come in and old fluid to go out. Remember, the fluid in the synovial joint is going to allow for um, the chondrocytes to be essentially nourished. If you are not replenishing that fluid, it doesn't have as much nutrients. Those cells can start to die. It can cause issues with that joint. It can cause a lot of pain. Now, when I was 15 and they did my knee surgery, Not only did I tear my meniscus, but they actually also found out that I had arthritis. So arthritis is essentially it's a collective group of different types of diseases of joints that essentially the joint has endured some type of inflammation. So every time it rains, I can feel it in my left knee. Typically, people who have surgery on joints or have hip replacements, typically you can feel it in the joints because remember, there is air in those joints. So when the weather changes, the pressure of the air around us changes. So that pressure either puts too much pressure on those air bubbles inside the joint, or sometimes it doesn't put enough pressure on them. And so that can cause, we can feel that. Our synovial joints have nerves. They can feel the change in pressures. So think about if someone's like blowing up a balloon inside your joint, you'd feel that. So that's what it's like when people have arthritis and the barometric pressure changes when the weather changes. You can also have what's called gouty arthritis, or you usually hear it called gout. This typically happens more in males. So essentially, with gout, there's essentially a bunch of uric acid crystals. So you get those crystals from like eating things like spinach, things that are really high in minerals. You'll essentially get that trapped in your bloodstream, and then your bloodstream is going to deposit that into the synovial fluids. Those synovial fluids are going to deposit that on top of the cartilages and the bones in the joints. So typically, we usually find gout in bigger joints like our toes. Remember, gravity is going to pull a lot of our blood down to our feet. And so our body and our heart essentially has to fight gravity to pull that blood back up. But typically, essentially, those minerals are going to sit down into our joints because of gravity. And essentially, remember, our bones are made out of calcium and phosphate, which are minerals. Those are going to essentially give the bone their structure and makes it hard. So imagine if you're adding more minerals to your bones and it starts to fill up those joints now that fluid is a lot of minerals and they start to calcify. So essentially, it almost feels like it's fusing your bone together with bone. So think about like your fingers. You're able to bend your fingers because of those synovial fluid in your joints. But if that synovial fluid becomes a lot more calcium and a lot more deposits of minerals, you won't be able to really bend your finger because essentially it has fused all these bones together. So you got to be careful with things with uric acid. So one way you can actually stop that is by drinking like things like lemon juice, cranberry juice, things that are acidic. By having things that are acidic, it's going to start breaking down those uric acid crystals. So that's why you have to drink acids essentially is to break down or help flush out those crystals. And it usually kind of takes a while for it to really kind of flesh out. You have what's called osteoarthritis, which is essentially termed wear and tear, which means that over time that you have essentially worn down your joints, and essentially bone starts rubbing up against bone. Rheumatoid arthritis, which I hear more about than anything, rheumatoid arthritis is an autoimmune disease. So, referring to autoimmune, that's going to mean that auto means self, immune means your immune system. Your immune system starts attacking your joints. Once it starts attacking your joints, it starts killing them. It starts killing those cells, it starts killing those chondrocytes, it kills the hyaline cartilage. And essentially, then you're going to start having bone on bone. And so this is essentially what people who have rheumatoid arthritis is going to suffer with. So you can see that their knuckles are really big. They're really essentially inflamed. It kind of essentially causes their fingers to be pushed out the way. So this is what, when people have rheumatoid arthritis, it's really kind of noticeable because if you know what you're looking for, you can usually always tell their knuckles are really kind of really big. Their fingers are kind of cocked to the side. Their fingers are usually going to be really swollen up. this is an autoimmune disease. Your immune system starts attacking your joints, and you can actually see that here. Here's an X-ray, and you can see how the joint right here, and then yet the finger should be straight, but the finger is now cocked to the side. Same thing with the thumb here. The thumb is supposed to be nice and straight, but you can see that it starts making like a backwards L shape. So this is what can happen to joints, and here you can actually see it happening in the wrist as well. All right, that wraps up joints. I hope you learned something new. I just hope that you exercise often. Exercising keeps those joints nice and fresh. Um, but again, I hope you learned something new. I hope that we were able to tie in bones and joints and those bone markings now that we can see how everything's working together. So when we get to the muscle chapter, we can see how those muscles and tendons and bones are all working together. All right, until next time, I will see you then.